guys, how is everyone doing? Such a pleasure to be here, and just to see everybody in person is just an incredible treat. So what an amazing job that HLTH has done this year.
Being able to pull off an in-person conference of this size, even in this late in the year is still pretty impressive. I know we canceled a lot of events because we didn't think we could do it, so
yeah,
impressive.
Totally. So, we don't have long enough, so I'm just going to get straight into it.
Sure.
So when you and I were chatting about this backstage, we decided that we were not going to make this whole 20 minutes about COVID, but I did want to kick off with a COVID question. Sure. So at this point, folks are calling this the pandemic of the unvaccinated, and we still have so many people in this country that just will not get the vaccine. Your company, CVS, plays such a huge role in this vaccination process. What do you think you should be doing more of to get that final group of Americans through the door, if it's even possible?
So that's a really good question and a really hard one. So I think where we're sitting as a country right now, it seems to be from the data that the employer mandates matter. So we've seen when we put out an employer mandate, the number of people who are unvaccinated or unwilling dropped in half, and we haven't even gotten to the point of where we've really started to send letters to people saying, we're going to be replacing your jobs. And if you look at what's happened with some of the major health systems, they're reporting, less than 1% of people. So I think some of that is going to help. There is a cadre of the population that's just not going to get vaccinated for all sorts of reasons we don't need to get into. And I think what I've seen, at least a little bit of the data would suggest that something on the order of 83 to 85% of people in the US are seropositive. Either they've been infected or they've been vaccinated. And the best guess is, and again, I'm not an epidemiologist, I didn't stay at the Holiday Inn Express, so just take this with a grain of salt, is about 95% seropositive would sort of get to herd immunity. So as the vaccinations for 5 to 11 comes out, that should get us over, plus the continuing infection, towards the end of the fourth quarter. And if you then play it out and look back over the influenza epidemic, it lasted 2 years. So it looks like these things kind of last 2 years. So I think we need to do, as a company, we need to, and all large companies, kind of continue to educate, inform, talk to people. We're privileged that we have hundreds of health professionals. Like, I personally talked to about 100 people to try to get them to be vaccinated. I got 22 that I know of, so I'm not batting great, but I'm doing okay.
That's not bad. I think I'm like 0 of 100.
So I think we have to do those things, and then what we do obviously is make it easy, right? Make it easy to schedule, make it easy to get vaccines, make it easy to get boosters, in all communities. So that's what we're doing.
Okay, I know you said you're not an epidemiologist, but when do you think we're going to be looking this thing in the rearview mirror?
Again, if you had made me bet, I would say end of the first quarter of 22.
Okay, all right. So, well, we'll hold you to that.
I hope so, because I got a lot of vacation planned with travel at the end, in the middle of 22. So maybe it could be wishful thinking, in fairness.
Okay, so we covered COVID. Now I want to get into the big topic, I think, and one of the great social issues of our time, and that is the cost of prescription drugs in this country. And, as a representative of Caremark, there's a lot of folks in this room that would say that your business had a role to play in that, whether for good or for bad. What is your view on why this became the issue that it became? Because 10 years ago, we probably would not have been sitting here talking about drug pricing as one of our major topics for all sorts of reasons. And now it's the thing that in healthcare we all need to be thinking about and managing. So why is this such a big topic? And then, let's drill down from there and figure out what we can do about it.
So on one hand, I would tongue in cheek say, I don't know why it's such a big topic, right? Because if you look at national drug expenditures and national health expenditures, it's 10% of drugs. It's been about that number for a long time. If you look at the trends over time that have been reported by the large PBMs, largely in commercial populations where you have the ability to manage, it's single-digit trend, and low single-digit trend, often less than medical inflation. So that would be my tongue-in-cheek answer. I don't know why. I think the answer of why it is that we're at a point now where two forces have collided. So one is you have a lot of people in high deductible plans, and you have a lot of drugs where the cost is eye-poppingly expensive. So in the past, people would have not known what the cost was. They would have paid their copay and gone home. But now, particularly for specialty medications where, the drugs can be anywhere from $6,000 to $10,000 or more a month, that January experience is really unpleasant, and that makes it a political issue appropriately. And to some extent, you look at kind of high deductible plans and you think about, why they exist and do they make sense? And there are some things where they could. But if you're diagnosed with multiple sclerosis and your choice is between one $7,000 drug and the other $7,000 drug, your only rational choice is don't get multiple sclerosis, and that was taken away from you. So I think that's one of the real issues, the reasons that we're talking about it now, which is the sheer brand, the sheer price target that brand name drugs are coming out at, in the last decade.
So what do you think needs to happen? I mean, people have talked about all kinds of different regulations that could be passed. There's talk of a lot of things that the PBMs could be doing, things like reference pricing. What are you in favor of?
So I think there's a long list. So if you start out, when I look at what we do as a company, for example, we use a formulary, a drug list, that's very highly generic. So the first is drive generics to the greatest degree possible. And what you see, unfortunately, is that when a drug goes generic, the volume of that drug, of that molecule, goes down over time. And it can go down pretty quickly because the brand, the brand kind of promotions. So I think one thing is drive generics. The second thing is drive competition. When you see, I'll use some data from 20 years ago, so I don't disclose anything proprietary, but in the angiotensin receptor block class, which was a class of high blood pressure drugs, first one came out, for then it was high price, now it would not be. By the time you got to the 7th product, there was about an 80% discount on the products, able to create a lot of competition. Now, if you look at, I'll look at the autoimmune space, kind of the Humiras, Enbrels. We have 8, 9, 10, 11 drugs, but the amount of competition is much less. And so until the biosimilars evolve for these drugs more, especially for the self-administered ones, that will drive the competition. That I suspect will drive, not suspect, I know will drive the price down. So really, it's, I think the first answer, particularly in this country, is how can we accelerate competition? How can we reduce the impact of kind of follow-on brands and things that take away that generic deflationary trend? Because the reason that we've had 1%, 2%, 3% drug trends is that the deflationary impact of generics is offsetting the inflationary impact of brand prices.
And reference pricing?
So it's a good question. And so by reference
and maybe
pricing,
explain it, yeah.
Yeah, so there's two forms of reference pricing. So reference pricing A would be, we're going to set a reference price in a category, and pay that, and then above that, the member pays. That's just another form of high deductible plan to me. It's more cost shifting. Maybe on the margins in certain categories, you could get more generic pricing. Reference pricing, the other reference pricing that's been proposed is reference pricing US prices against international prices. So I'll first give a disclaimer, this is Alan speaking, not CVS Health, right? But you would have to look at it and say, on balance, if you were going to reference price on a GDP basis, as long as it was the ceiling and not the floor. Because if you look at what happened in 2015 with Harvoni, the ability to create competitive pricing, the price of Harvoni in the US was less than the price of Harvoni in Europe with government controls. So I would never want to be in a scenario where we were setting prices without the ability to negotiate, especially when you're staring in the front of a biosimilar wave in specialty that I think is going to drive down prices far more than anyone is going to be able to go, so I think we want to be really careful. I mean, it's got a certain attractiveness to it, right? You don't want to subsidize the rest of the world, but it also has its downsides. And in general, as a free marketeer, I think in general we can do a better job if there's more competition and we level the playing field a little bit more.
And to that end, if you got fired from CVS tomorrow, and you had to go out there and start something, what's your next big business idea?
You know something I don't know? Just checking. So it's a good question. I mean, I tend to lean towards medical devices right now because I'm super interested in it. But on the digital health side, I probably think about probably plumbing, right? And what I mean by plumbing is there's nothing in healthcare that works easily. So are there tools, are there capabilities that if you built, multiple companies could purchase and buy that would improve the member experience and improve the consumer experience, make it frictionless, make it much more of a quote unquote modern interaction. So I would probably go on the plumbing route. That would be probably my most likely one.
So something deeply unsexy.
Deeply unsexy. If you want to do something really sexy, then I would say I've always found that every healthcare website always ends with the same thing. This is for entertainment or education purposes only. Go talk to your doctor. So completely not helpful. So if I was going to try to do something much sexier, I would try to build an AI-powered engine that would really help people understand both what they should do, because we do far too little of the things we should do, and what you shouldn't do, because we do far too much of those.
So for all the founders in this room, and I'm sure there are a bunch sitting here in the audience, imagine you are somebody that's building that AI-powered engine, that's building that essential plumbing. How do I get into a CVS, and how do I get in front of someone like you to pitch my product and service at an organization where there's so many people with, say, an innovation title, but it's very unclear from the outside who to be in touch with first? That
is both an easy question and a hard question. Just call me and I'll get you the right person. And I'm serious. It's alan.lotvin@cvshealth.com. I think that in general, for any small company to get into a big company, it requires someone to take an interest and be excited by your pitch. Because what big companies do that's terrible, and I will tell you, I do try not to do this, is we torture little companies. Right? By the time you get through all of our vendor approval processes and security detail,
that's pretty honest. You don't hear folks saying that.
No. We do. It's like what happens. So it's really how do you get the person who's sponsoring you to be willing to say, this is never going to work. Right? I love what you're doing. It's not going to work. Or if it's going to work, let's try to bring it through be the sponsor to bring it through large companies, because large companies are just large conglomerations of lots of people, and it's people, right? So you got to find the right person.
And how do you do that?
I would start. You could start with people friends of friends. Most companies have a strategy officer or a business development person who probably gets a lot of these, conferences like this, and just find the right person who's willing to help you find a decision maker. But always be cautious that, and you should be upfront also that, listen, if it's not going to work, just tell me. Because I have a lot of friends who've been with, who've oh yeah, I'm going to get a contract with X, Y, and Z giant company, and 2 years later, what happened? Well, I didn't get the contract I thought I was going to get, and now I ran out of money. So it's you just got to be careful about large companies.
Yeah, I think, we've heard the term death by pilot kind of be bandied about in the digital health industry. Just, sometimes working with a company of your size and scale, startups can get these pilot agreements and then they don't go anywhere, and they've just wasted a bunch of time and resources on that.
Right, if you're going to do a pilot, make sure it is a pilot that, if it worked, can scale to a business or mission critical. It's not just a science project, to use my friend Dean's term. Right? Just find a pilot that really, and a commitment that says, if this works, we're going to go to the next stage. Right? This isn't just activity, because a lot of people in large companies often measure themselves by activity. Oh, I did 75 pilots. Okay, none of them worked. Right?
Absolutely. So for those who are just starting out in digital health, but maybe very early in their career, do you, and this is our last question, but okay, do you recommend that they go and work at a big company like a CVS and do a tour of duty where they really go deep on understanding kind of something inherent to your business and go from there, or would you say skip it and go straight to a startup?
So that's a really hard question. I mean, I think it depends on what you're trying to do, right? If you want to have huge impact in the world, in healthcare these days, then the way to do it, I think, is to work in a bigger company with a narrower scope, and maybe do less truly revolutionary things, but really make it better for a huge number of people. Like on balance, making 100 million people live a day longer, you've saved gazillions of lives. If you're more focused on a broad scope, and you also, to your point, you'll learn how it works. If you're convinced that you have kind of the next greatest, tool or approach, and that learning how the current system works is just going to kind of slow you down, pollute you with bad thoughts, or you just want to have a broad role, then go to a startup. I think it really depends on what you're trying to get out of your first job or second job.
Thanks so much. Great advice there. It was a pleasure speaking with you, and
great meeting.
Thanks to everyone in the audience.
We appreciate you taking the time.